Hey guys, I wanted to make a quick video on something that causes a massive amount of post-test panic, and that's when your CCS cases end early on the real exam. If you've been practicing or if you literally just walked out of day 2 at Prometric, you know the feeling. You're 5 minutes into a case, you order a couple of things, you advance the clock, and suddenly the screen transitions to the next patient. Your stomach drops because you think, all right, either I completely nailed that or the patient just died in the hallway. Here's what's actually happening under the hood. The Primum software runs on pretty straightforward logic gates. When a case ends early, it simply means the simulation reached an algorithmic endpoint. The system has officially gathered enough data about your management pattern to grade you, so it cuts the cord. But here's the trap. You cannot assume a short case means a perfect score. Yes, it can mean you were highly efficient, but it can also mean you forgot a critical safety step, like advancing time for an unstable patient before checking their vitals again, and the system terminated the case because the patient deteriorated. Early closure is just a timing signal. It is not a score report. So how do you actually review this? I put a table together in the article linked below to help audit this without getting emotional about it. If your case ended early, look back at your sequence. Did you stabilize the airway and vitals first? Did you order targeted labs, give the treatment, reassess, and set a final disposition, like admitting them or setting up outpatient follow-up? If you hit all those notes in a clean sequence and the case ended, you're fine. You did your job. The dangerous early ending is when you get order heavy. You get anxious because the screen is quiet, so you start shotgunning orders, invasive tests, random consults, just because you have time left on the clock. The grading script actually docks you points for poor clinical judgment if you do that. Your goal isn't to use the whole clock, it's to stabilize, confirm, and close safely. Let me show you exactly what this looks like with a common trap, like a standard severe pneumonia case in the emergency department. A patient rolls in with hypoxia, fever, and a high heart rate. You're moving fast, so you order your chest x-ray, your blood cultures, and your IV antibiotics. All of those are completely correct orders. But then you immediately click advance time 4 hours to wait for the labs to come back, without putting the patient on supplemental oxygen first. The second you click that time jump, the engine essentially calculates that you left a hypoxic patient on room air for 4 straight hours. The patient's oxygen saturation tanks, they go into acute respiratory failure, and the screen suddenly cuts to black. The case ends early. You didn't finish early because you got a perfect score. You finished early because you missed a critical safety filter, and the simulation timed out to prevent further clinical damage. That is why sequencing matters infinitely more than just having the right orders on your list. Stop stressing about the clock, focus on the sequence, and let me know if you have questions in the comments.